Thank you for watching this informational video about a randomized trial evaluating electronic alerts for acute kidney injury. Acute kidney injury is very common in hospitalized patients. About 20% of patients in the Yale Health System experience AKI during a hospitalization. And at Yale, a hospitalized patient with acute kidney injury has an inpatient mortality of 10% compared to just 1.5% for a hospitalized patient who does not develop acute kidney injury. There is excellent observational evidence to suggest that early recognition of acute kidney injury may improve clinical outcomes. How are we doing in terms of recognition? Well, at Yale, chart documentation of acute kidney injury is roughly 30%. Now, documentation might not be a true proxy for recognition, but we looked at some of the medications that people are receiving in the hospital while they have AKI, and you can see the results here. Among patients who were taking nonsteroidal anti-inflammatory drugs at the time of AKI, 59% got at least one more dose within the 24 hours after AKI developed. 65% of patients receiving an ACE inhibitor received at least one more dose of an ACE inhibitor within the 24 hours after acute kidney injury developed. In terms of other best practices, you can see our urinalysis rate is just 16%, despite the fact that urinalysis is universally recommended in patients with AKI, and we only monitor a subsequent creatinine in 65% of our patients who develop AKI. Will alerting providers to the presence of AKI improve these outcomes? That is the purpose of this trial, and it works like this. We electronically monitor all hospitalized patients for the development of acute kidney injury. When a patient develops acute kidney injury, they are randomized to the alert or the usual care arms of the trial. In the alert arm, a pop-up alert, which you will see in the next slide, is delivered when the patient's chart is opened. In the usual care arm, nothing happens. We measure several process outcomes, including our best practice metrics, which include things like the administration of iodinated contrast, rates of urinalysis, and rates of subsequent creatinine measurement. And we also importantly look at clinical outcomes like the progression of acute kidney injury, dialysis, and death. This is an example of an alert you may receive when you open a patient's chart. It tells you that the patient has been identified as having acute kidney injury and provides you with some of the relevant creatinine values over the last 7 days, including the most recent and the high and the low. The alert reminds you that this is a randomized trial and alerts do not fire for all patients with AKI, so please keep an eye out for AKI in all of your patients. The alert gives you the opportunity to open an order set. This order set contains many of the AKI relevant diagnostic orders that you may wish to consider, like subsequent creatinine measurement, urine output measurement, and urinalysis. You can also add AKI to the problem list for this patient right from the electronic alert. Finally, you're given an opportunity to agree or disagree with the assessment of AKI. If you agree, alerts for this patient will be suppressed for 48 hours, only for you. This will not affect alerts being seen by any other member of the care team. If you disagree, a dialog box will open, allowing you to tell the investigatory team why you disagree so that we can investigate any problems. Once you click on agree or disagree, you can click the accept button, which, as I mentioned, will suppress alerts only for you for 48 hours. Otherwise, you can click dismiss and the alert will pop up again the next time you open the patient's chart, provided they still have acute kidney injury. Many providers have concerns about how many alerts they will see. Over a 1-month pilot period in the Yale New Haven Hospital MICU, 77 patients were randomized. 509 providers interacted with those charts, but there was a median of just 1 alert per provider a month, and 186 providers never saw an alert. In other words, we hope that these alerts will not interfere with your workflow significantly. Of course, we are doing this as a randomized trial to evaluate the efficacy in terms of clinical parameters that matter to patients. We do not wish to add to the alert burden with an alert that doesn't actually improve the care of our patients. This trial is sponsored by the National Institutes of Health, by the Yale University School of Medicine, and by Yale New Haven Health, and we thank all of them for their support. Please contact us with any questions. Thank you very much.